এখন লাইভে চলে আসছে শুরু করতে।
ওকে, থ্যাংক ইউ। বিসমিল্লাহির রহমানির রহিম। আমি আজকে আলোচনা করব চ্যাপ্টার 27 টর্সো ট্রমা। জাস্ট 1 মিনিট, আমি আমার আইলাইনারটা ঠিক করে নেই, কেন জানি এটা কাজ করছে না, সরি। ওকে, আমি আজকে আপনাদের সঙ্গে আলোচনা করব চ্যাপ্টার 27 বেলিয়ান লাভস টর্সো ট্রমা। আমি প্রথমে দু একটা কথা বলি এই চ্যাপ্টার সম্পর্কে। ট্রমা ওভারঅল আমাদের পরীক্ষার জন্য খুবই গুরুত্বপূর্ণ। এখান থেকে লং কেস থাকে এবং যে লং কেসগুলো থাকে সেগুলো সাধারণত সিনারিও দিয়ে শুরু হয়, অর্থাৎ একটা সিনারিও দেয়া হয়, ওই সিনারিওর মধ্যে একটা ডায়াগনোসিস থাকে। হয়তো আইদার ইট মে বি লিভার ইনজুরি, ইট মে বি নিউমোথোরাক্স, ইট মে বি স্প্লিন ইনজুরি, ইট মে বি পারফোরেশন অফ হলো ভিসকাস। সো এই সিনারিও থেকে আমাদেরকে মেইনলি ওই যে অর্গানটা ইনজুরি দেয়া হয় সেই অর্গানের ইনজুরি নিয়ে আমাদেরকে প্রশ্ন করা হয়, সেই প্রশ্নের উত্তর দিতে হয়। কিন্তু ওভারঅল আমাদেরকে অবশ্যই এখানে ATLS প্রোটোকলটা, অর্থাৎ CABCD এই জিনিসগুলো আমাদেরকে লিখে আমরা এর মধ্যে, যেমন এতে এয়ারওয়ে, বিতে হলো ব্রেদিং, সিতে হলো সার্কুলেশন, দেখা গেল যে একটা ট্রমা পেশেন্ট ইন্টারনাল ব্লিডিং হচ্ছে, তখন আমি এই যে সি অংশে এসে আমাকে একটু বড় ইলাবোরেট করে লিখতে হয়। সো এই টোটাল জিনিসগুলো একটু বোঝার ব্যাপার, একটু জানার ব্যাপার। আবার সেই ইনজুরির ম্যানেজমেন্টটা কেমন হবে সেটা অনেক সময় আমাদেরকে বুঝতে হয়, মানে আমাদেরকে সেটা আসলে জানতে হয়। অনেক স্টুডেন্ট যেটা করে সেটা হলো যে তারা দেখা গেল যে তাদের কাছে জানতে চাওয়া হয়েছে যে একটা লিভার ইনজুরি ATLS প্রোটোকল অনুযায়ী আমরা কিভাবে ম্যানেজ করব। সো এখানে আমাকে মেইন ফোকাস করতে হবে লিভার ইনজুরিতে। কিন্তু দেখা যায় যে তারা A, B এবং C এই তিনটা নিয়ে অনেক কিছু লিখতে শুরু করে, লিখে তারপরে লিভার ইনজুরি নিয়ে সে আর লিখার সময় পায় না, বা তার অতিরিক্ত সময় নষ্ট হয়, সে অতিরিক্ত লিখে ফেলে। সো এই জন্য টোটাল ট্রমার যে চ্যাপ্টারটা আছে এখানে লং কোশ্চেন লেখার জন্য আমাদেরকে এই জিনিসগুলো ভালোভাবে পড়তে হবে। আর এখানকার ভালোভাবে পড়ার চেয়ে আমি বলবো যে ভালোভাবে আমাকে বুঝতে হবে এবং আমাকে প্রত্যেকটা জিনিস ওভাবে মনে রাখতে হবে যে কোন অংশে আমাকে কতটুকু লিখতে হবে। সেকেন্ড যেটা হলো যে এখানে প্রত্যেকটা ডিজিজ, অত্যন্ত অনেকগুলো ডিজিজ আছে, খুবই গুরুত্বপূর্ণ। এগুলো ভাইভাতে জিজ্ঞাসা করবে, অথবা রিটেনে অন্য কোনো প্রশ্ন আসবে, অথবা ওসপিতে এখানে যে এক্সরে সিটি স্ক্যান গুলো আছে এগুলো নিয়ে এখানে আলোচনা হবে। টর্সো ট্রমার মধ্যে আসলে চেস্ট ইনজুরি এন্ড অ্যাবডোমেন ইনজুরি বোথ আর ডিসকাস ইন দ্য টর্সো ট্রমা। সো অ্যাবডোমেন ইনজুরির মধ্যে দেয়ার ইজ এ লিভার ইনজুরি, স্প্লিন ইনজুরি, কিডনি ইনজুরি. So in Belian Loves, these all things are not written in details. So we have to read these many things from other books, but we should know the principle of management from Belian Loves. That's why we should read the Belian Loves. Then suppose what is the principle of management of liver injury? We must read from Belian Loves, but from what are the type of liver injury? We should read it from another book, because there are 5 types of liver injury, and these types is not written in the Belian Loves. So Belian Loves এর চ্যাপ্টার 27 সম্পর্কে এই দুই একটা কথা বলে আমি আজকে শুরু করছি Belian Loves with me এর চ্যাপ্টার 27 টর্সো ট্রমা। আমরা এখানে আজকে বেসিক্যালি আলোচনা করব হলো চেস্ট ইনজুরি যে ডিজিজগুলো আছে সেগুলো নিয়ে। আমরা যদি দেখি, দিস ইজ আওয়ার চ্যাপ্টার 27 এবং এটার আমাদেরকে torso trauma, our learning objective is that the management of trauma is based on physiology as well as anatomy. And then holo gross surgical anatomy of the chest and abdomen, pathophysiology of torso injury, strength and weakness of clinical assessment in the injured patient, use of special investigation with their limitation, operative approach to the thoracic cavity, the specific feature of emergency room thoracotomy for hemorrhage control, the indication for and technique of the trauma laparotomy. We will learn this chapter about the thoracotomy and we will learn this chapter about the ল্যাপারোটমি। সরি, আমার পেনটা আজকে আমি সঠিকভাবে ইউজ করতে পারছি না কোনো একটা টেকনিক্যাল কারণে, সো আমি এগিয়ে যাচ্ছি, সমস্যা নাই। দ্য ইন্ডিকেশন ফর অ্যান্ড টেকনিক অফ দ্য ট্রমা ল্যাপারোটমি, দেন হলো ড্যামেজ কন্ট্রোল সার্জারি। I want to say something about the damage control surgery. Damage control surgery in belly and lungs is discussed in many chapters. So when we read the damage control surgery, at that time we must read all the things in together. So I don't discuss this damage control surgery in my previous class, but after of course I will discuss this thing from all these chapter. There are many disease and condition in the belly and lungs like that, like this damage control chapter. What is the condition? That one disease in discussed in the different chapter. So when you read these topics, then you should read from all these chapters, because some information are written in this chapter, some information in this chapter. Like that, I want to tell you another disease condition, that is the necrotizing fasciitis or Fournier's gangrene or Melinis synergistic necrotizing fasciitis. This thing also in written in different chapter. So in belly and lung, what I used to do, I always write in belly and lungs that the other name of the chapter of this condition. Okay, let's start with the introduction. Sorry, my pen is not working. Let me try again for the last time. I don't know what is that. Just sorry for the interruption. Okay, start with the highliner. Introduction. Because injury does not respect the anatomical boundaries, that means we divided our body as a abdomen and thorax, and it is a artificial differentiation. So when an injured patient come to us, the injury does not respect the anatomical boundaries. So there may be associated injury in the abdomen as well as in the thorax. So that's why in belly and lungs, torso trauma is discussed in one chapter. Torso is generally regarded as the, what is torso? So torso is the main part of the human body, particularly made up of the chest and abdomen and the pelvis. So chest, abdomen and pelvis, these three things in together we call it torso. So head, neck, arms and leg, these are not included within the torso. Why these things is happen? Because injury may associated with abdominal injury with thoracic injury or abdominal injury. That's why if we see the figure 27.1, the causes of death in trauma, then we will see that bleeding is one of the important cause for trauma. Around 39% patient died from bleeding. Then holo central nervous system injury. So in trauma chapter, in many chapter, many things, bleeding must be kept in mind. In our personal practice as a physician in an emergency room, or in a MI room, or an emergency and casualty, or in a periphery, we must learn this type of trauma patient, because patient don't know where to go. So they may rush into any hospital nearby, and how you may be a junior doctor, but you have to manage something. You have to manage something. So that's why we must learn this trauma and trauma related emergency management very meticulously. Next, thoracic injury. Some word about the thoracic injury. You can see 25% of all severe injury are related to the thoracic injury. So 1/4 of the trauma patient may have thoracic injury. So we must learn the initial management of thoracic injury patient. And then another thing, 80% of this patient can be managed without non-operatively. That is, the 25% patient of severe injury is thoracic injury patient. Among these 25%, 80% of the patient we can manage non-operatively. So what is the non-operative treatment? How we should manage as a doctor, we must learn that. Now come to the clinical indication of potential ongoing bleeding in a torsotrauma. These things we also discussed before, because what is the clinical feature of bleeding? What is the clinical feature of bleeding which we cannot see? That is the same thing. So in physiological and anatomical clinical feature, we will the same thing. A patient who is on bleeding, whose blood is going out, his respiratory rate will be increased, his pulse rate will be increased, his blood pressure will be coming down, his serum lactate will be increased due to the shock. And anatomical, we can see the bleeding, or we can suspect that the injury is closely related to a vessel. So if we found this type of clinical feature, that is the increased pulse rate, decreased blood pressure, increased respiratory rate, we may suspect that patient may have a internal bleeding, or patient may have a ongoing bleeding, and then we should do the necessary action to treat the patient. Now come to the how we will investigate a patient of chest injury. First thing, maximum emergency condition in chest injury must be diagnosed clinically. We will see it in the next slide or this slide, that it is written that maximum chest injury, emergency chest injury or life-threatening condition in the chest must be diagnosed by clinical examination. So we should learn this clinical examination. We should know this clinical examination. We should know this condition. We should know this, how to diagnose and how to treat this clinical condition, because we don't have the time to tell patient to go and do a chest X-ray and then come again, like a patient of tension pneumothorax, patient of massive hemothorax. We cannot ask that. So we must take the decision on clinical ground, and we have to be confident on our clinical examination that I can diagnose these things properly. Okay. So after this somewhat, there must be some investigation which can help us to investigate the chest injury. What is this investigation? First, coming to the chest X-ray, chest radiograph. Okay, this is an important investigation. Then holo chest drain. This can be a diagnostic as well as therapeutic condition. And the most important is the spiral CT scan. But in Bangladesh, we know that in our all center, like in Upojela or union level hospital, we don't have the facilities of CT scan. So chest X-ray will be the first investigation of choice, and it is also written in the Balian Law that chest X-ray is the first investigation of choice. Next one investigation is not written here in the box 27.2. That's why I bring it here. That is a ultrasonography. This is not the conventional ultrasonography. We tell it first or E first, first and E first. So we must remember the term. The ultrasonography of a trauma patient is first or E first. Yeah. First is the only for the abdomen, and E first is the extended first. That's why. So what is the stand for first? Extended focused. This is the meaning of first. Focused assessment with sonar for the trauma patient. So these have a separate protocol. This ultrasonography have a separate protocol. It not always should be done by a radiologist. A surgeon, like a stethoscope, ultrasonography is becoming an instrument to a surgeon like a stethoscope. So if we can understand, we can do the ultrasonography for our patient, it will helpful in the management of the patient. So what are the investigation for a chest injury patient? First investigation is a chest radiography or the chest X-ray. Then holo chest drain may be used as a therapeutic as well as diagnostic purpose. Then holo we can tell it a spiral CT scan, or we can tell it CT scan of the chest with 3D reconstruction with contrast, or as a trauma series CT scan. We see that this CT scan is whole body CT scan with IV contrast, whole body CT scan with IV contrast. That also a part of our this chapter and chest injury management. And the other investigation is ultrasonography. Other than that, we must do the blood X-ray, blood cross-matching, blood grouping, then holo complete blood count, patient diabetes status, patient kidney status, and other comorbid condition status by evaluation of blood and in as early as possible. So these are the investigation we should retain in examination. Okay. Now come direct or indirect 50% of trauma death, or 50% of patient died due to trauma due to chest injury. It may be directly or it may be indirectly. So that's why chest injury is so important. And next line is that 80% can be managed by non-operatively. So we should learn. We should not always, we cannot tell the patient go to a surgeon or can go to a thoracic surgeon for the management, because 80% patient of chest injury can be managed is non-operatively. Then this is the investigation. Now few words about the FAST and eFAST. Okay. In FAST, what we will do? In FAST, looking for the where we will abdominal cavity, see the paracolic gutter, then holo subdiaphragmatic space and pelvis. Orthat in FAST, when we are doing a ultrasonography in emergency condition, in a trauma patient, we will not see the whole organ or whole abdomen like a conventional ultrasonography. Suppose in FAST emergency condition, we will not see the gallbladder. We will not see the kidney. In FAST, what we will do, we will see the is there presence of any blood or not, actual presence of blood. This is the principle of FAST or eFAST. After that is, we will see is there any accumulation of blood or not. Then if our patient is hemodynamically stable and patient don't need an emergency surgery, then we can go for a conventional ultrasonography. So that is the basic principle of FAST. What is this? It is an emergency ultrasonography done only for the trauma patient. And why we should done it? We should done it to see any actual presence of blood. And where we should search the blood? This is the 1, 2, 3, 4. One holo both paracolic gutter, 2 both subdiaphragmatic space and pelvis. Or within the abdomen there are 5 places. In abdomen we will search for presence of blood in 5 places. What are the 2 paracolic gutter, then 2 subdiaphragmatic space, অর্থাৎ right subdiaphragmatic space অর্থাৎ just above the liver অথবা below the liver, and left subdiaphragmatic space, that is the near the spleen and the pelvis. And when we will tell the eFAST, then we will assess the cardiac tamponade. Okay, so that's why it is calling eFAST. FAST for 5 place and eFAST for +1, that is the cardiac tamponade. That is there any free blood collected within the pericardium. Okay, next come to the management. Management of key, management of what? Management of chest injury in a grossly how we'll manage of chest injury. After that, when we read the tension pneumothorax, when we read the hemothorax, that time we will read separate treatment. Here it is the management of general management of chest injury. What is here? It is told that like that. what we should do in penetrating injury, what we should do in the sucking chest wound, what we should do in the blunt injury. That is written here, management. So see, in penetrating injury, most patients who have suffered injury to the chest can be managed with appropriate resuscitation and insertion of a intercostal drain. What are the principle of a management of or treatment of a penetrating injury? This is the insertion of a intercostal drain, okay, this is the basic management. Other management, we must admit the patient in hospital according to the status. We must admit the patient in ICU or HDO or general ward. Then we must insert a chest drain, we must give a painkiller, we must give antibiotic. These all things are coming. So here it is only written the principle. Then what we will do for a sucking chest wound, when we read the tension pneumothorax, that time we will understand what is the sucking wound. Sucking wound is that type of wound where blood is going inside the chest, that is the between the pleura and lung, and this air is creating a pneumothorax, and when it's in one way, that time the pneumothorax is gradually increasing and threaten the life of the patient. Here what type of injury it is discussed, that there is a big wound. In that case, what is telling, this should be converted in a close. This type of injury should be closed on 3 sides, and it should be making a one-way valve. After that, we'll insert a chest drain, and then we will repair this chest wound. What is practice in our country? I must tell that in any type of injury, you are taking the patient, or patient is coming to any hospital, we first want to repair the wound. It may be lacerated wound. We even don't irrigate the or clean the wound properly. We must, how many stitches are given? So in Bangladesh, any injury, patient are asking, or patient relative are asking that how many stitches are given. Or koita shelai deya holo, eta holo guruttopurno. Kintu as a doctor, we must learn that before anything closing or before giving stitch, we should clean the wound properly, we should irrigate the wound properly, then we should give the wound. We can give a bandage. And in our practice, what we are seeing, that now someone is stitching something and taking the money from the patient. After that, patient is reporting to another hospital, and we should remove all the stitches and then irrigate and wash again, then close again. So our practice should not be like that. এটা আমাদের দেশের একটা, আমাদের দেশে যে দুর্বলতাগুলো আছে চিকিৎসা ব্যবস্থার, এটা তার একটা দুর্বলতা, যে আমরা যে কোনো ওন পেলেই প্রথমে ক্লোজ করে ফেলার চেষ্টা করি। আসলে আমাদেরকে তার আগে ওনটা অ্যাসেস করা উচিত, পেশেন্টকে পেইন কিলার দেওয়া উচিত, এবং যদি আমি ক্লোজ নাও করতে পারি, উই শুড ওয়াশ প্রপারলি, বিকজ এই যে ওয়াশের সঙ্গে, অর্থাৎ ইরিগেশনের সঙ্গে, ক্লিনিং এর সঙ্গে সময়ের একটা সম্পর্ক আছে। আমি 1 ঘন্টা পরে ওয়াশ অথবা ক্লিন করলে যেটা হবে, 2 ঘন্টা পরে করলে পেশেন্টের ড্যামেজ অনেক বেশি হবে। এই পার্টিকেল গুলো বডির মধ্যে অ্যাবজর্ব হয়ে যাবে, এই ফরেন ম্যাটেরিয়াল, টক্সিক ম্যাটেরিয়াল গুলো অনেক কিছু টিস্যুর মধ্যে চলে যাবে। সো আর্লি ওয়াশ ইজ ভেরি ইম্পর্টেন্ট। সো আমাদেরকে এটা জানতে হবে, আমাদেরকে এটা নিজেদের বুঝতে হবে, দেন আমরা পেশেন্ট এবং পেশেন্টের আশেপাশে রিলেটিভদের আমরা এই জিনিসটা বুঝাতে পারবো। আমাদের দেখা যায় যে অনেকে, আমাদের দেশে যেটা প্র্যাকটিস হয়, আমাদের মেডিকেল অ্যাসিস্ট্যান্ট বা হেল্পিং হ্যান্ডরা অনেক সময় আমাদের এই স্টিচ বা ক্লোজিং এর কাজগুলো করে ফেলে। সো আমাদের এই জিনিসগুলোর ব্যাপারে আমাদের যদি নলেজ না থাকে, আমরা তাদেরকেও বুঝাতে পারবো না। তারা আমাদেরকে বলবে যে আমরা 10 বছর ধরে এটা করে আসছি, 20 বছর ধরে এটা করে আসছি, যে আমরা নতুন ডক্টর হিসেবে আমরা যখন ওই সকল জায়গায় কাজ করতে যাব, তখন আমরা কিছু সমস্যা ফেস করব। সো লার্নিং শুড বি মাস্ট এবং কনফিডেন্ট, দ্যাটস ওয়াই। So what is about the blunt trauma, অর্থাৎ blunt chest trauma? We must intercostal or intermammary vessel. If there is a bleeding, we must suspect that in blunt trauma, the bleeding from the intercostal or internal mammary vessel. So if it is not bleeding is not stopped spontaneously, then we must go for a surgical procedure or other procedure to stop the bleeding. That is the management of penetrating principle of management of penetrating trauma, sucking chest wound, and blunt injury for a chest trauma patient. So this is the summary. Close management of chest injury. 80% chest injury can be managed by intercostal drain. So that's why intercostal drain is so important. And we must learn how to insert a drain in the chest. I think all doctors should learn that. Then hello, don't close sucking chest wound until a drain is placed. And if bleeding the persist, if bleeding is continued, chest need to be open. This is called thoracotomy, like laparotomy. When we open abdomen, it is called the laparotomy. When we open the thorax, it is called the thoracotomy. So next, come to the table 27.3. Here see, it is written the deadly dodgen. Deadly dodgen. There are 6 immediate life-threatening condition and 6 potentially life-threatening condition, and there are total 12 condition that is called deadly dodgen. আমাদের এই deadly dodgeনের 12টা ডিজিজের নাম মনে রাখতে হবে. We should remember these 12 disease. How I remember, I will discuss here, and you can follow my procedure, or you can separately see. First, what is this immediate life-threatening condition? There are 6 immediate life conditions. First one is airway obstruction, or that is related to the airway. Second, cardiac tamponade. So this is related to the heart. Then this is tension pneumothorax. It is related to the lungs. And another one, open pneumothorax. It is related to the lungs. Yeah. Then massive pneumothorax. It is related to the lungs. And flail chest, it is related to the lungs. So among the immediate life-threatening 6 condition, one is related to the airway, and one is related to the heart, and other 4 is related to the chest wall or chest or lung. So that's how we can remember first thing. So what are the conditions related to the airway? This is airway obstruction. What are the related to the heart? This is pericardial tamponade. What are the related to the lung? One is tension pneumothorax, one is open pneumothorax. So for pneumothorax, there are 2. One is tension pneumothorax and one is open pneumothorax. Both are immediate life-threatening condition. Then one is related to the bleeding. This is massive hemothorax, and one is related to the flail chest, or the abdominal, chest wall. So in that how অর্থাৎ আমরা এভাবে এই 6টা ডিজিজের নাম আমরা মনে রাখতে পারি, আমরা এটা মনে রাখার চেষ্টা করব. Then come to the potential life threatening condition. Same thing, one is related to the aorta, one is related to the bronchus, then one is related to the heart, one is related to the diaphragm, one is esophagus, one is pulmonary condition. Arthat for potential life threatening condition, 6 condition are related to the 6 organ. One is our aorta, one is bronchus or trachea, one is heart, myocardial contusion, one is rupture of the diaphragm, one is esophageal injury, and one is pulmonary contusion. Contusion means blunt trauma. Contusion means blunt trauma. Where we tell it bruise, this is when we tell this term for internal organ, then we call it contusion, like myocardial contusion, like pulmonary contusion, like liver contusion, like liver spleen contusion, like kidney contusion, same. Yeah. বাংলায় যদি বলি তাহলে থেতলানো ইনজুরি টাইপের একটা ইনজুরি. Okay. So from table 27.3 we read the name of the deadly dodgen, 6 immediate life-threatening condition and 6 potential life-threatening condition. We will remember it. Then now come to the individual disease one after another. First, this is tension pneumothorax. Here you can see that about the tension pneumothorax in belly and lungs, it is written in literature form, অর্থাৎ গদ্যের মতো করে লেখা. আমরা we should do the identify these things, and whatever is written in this chapter, it is sufficient for everybody, for post graduation, for undergraduation, for MBBS student, for 3rd year, 4th year, 5th year. What is written in the belly and lung, this is sufficient. but this written form is different. So আমরা যখন বেলিয়ান লাভস পড়তে শুরু করব ধীরে ধীরে আমাদের ভালো লাগবে। সো আমরা আসি টেনশন নিউমোথোরাক্স সম্পর্কে। টেনশন নিউমোথোরাক্স ডেভেলপ when a one-way valve air leak occurs in the lung or through the chest wall. I will discuss this in the next slide. How the pathophysiology or mechanism of tension pneumothorax. অর্থাৎ আমি যদি বাংলায় বলি টেনশন নিউমোথোরাক্সে এমন একটা কন্ডিশন তৈরি হয় যে বাতাস আমাদের ফুসফুসের মধ্যে যাচ্ছে, ফুসফুস না, আমাদের ফুসফুস এবং প্লুরা তার মাঝখানে এই স্পেসটার মধ্যে বাতাস জমা হচ্ছে কিন্তু সেটা বের হতে পারছে না। হ্যাঁ, অর্থাৎ দ্যাট ইজ এয়ার ইজ accumulated between lung and pleura, but it cannot go outside of the chest wall. That's why air is a tension is created there due to the pneumo. Pneumo means blood. Sorry, pneumo means air. So a tension is created by air within the thorax. That is called tension pneumothorax, and it is an emergency condition. It is a life-threatening condition, and it is an immediate life-threatening condition. So we should diagnose and treat the patient as early as possible. Okay. What are the condition developed in case of pneumothorax? That thoracic cavity without any means of escape completely collapse and compressing the affected lung. So this is an important thing. Air joma hoye ki kore lungs ke lung will be compress and collapse. Lung is like a balloon. So it is easily compress or collapse. So when tension is produced in the pleural space, the lung is collapsed, and even the mediastinum will be displaced in the opposite side and decreasing the venous return and compressing the opposite lung. This is the condition we find in a X-ray, chest X-ray in a tension pneumothorax patient. So we should remember this. What are the condition we find in a tension pneumothorax patient? Collapse or compression of the lung, displacement of the mediastinum in the opposite side, decreasing of venous return, and compression of the opposite lung. Now we see the cause, most common cause. What are the most common cause of a tension pneumothorax? That is penetrating chest injury, then blunt chest trauma with parenchymal lung injury, then holo air leak, then holo iatrogenic lung injury, then holo mechanical positive pressure ventilation. And another thing, that is the rupture of a bulla in a TB patient. It is not written in Bailey and Lux. We can write down here patient, or the rupture of a bulla in a tuberculosis patient, as pulmonary tuberculosis is common, still common in our country. So what are the causes of tension pneumothorax? First, penetrating chest trauma, then blunt chest trauma, then parenchymal lung injury, and then holo iatrogenic lung injury, then holo mechanical positive pressure ventilation. So we learned from this slide what is the tension pneumothorax, how tension pneumothorax is developed, and what is the condition developed in a tension pneumothorax patient, and what are the common causes of tension pneumothorax. So see, many information are within this 1, 2, 3, 4, 5, 6, 7, 8, 9, this 10 line. Next, this is the chest radiograph of a tension pneumothorax patient. If you see, this is the lung. Okay, if you see clearly, this is the lung. Okay, so we should know it. This is the lung. Okay. So lung was like that big organ, but due to this pressure of the air, lung is collapsed. This is called collapsed lung, and this is called collapsed lung margin. And now see, our trachea should be here, but trachea is shifted to the dead side. Our mediastinum here, mediastinum is shifted to the dead side, and this is the left lung, and we can see the left lung field, but there is a contusion. This is called homogeneous opacity. This is due to contusion. And this is the blackish area or radiolucent area. This is all the air. This is, you see the difference, this radiolucent area, and this is not so radiolucent area. So here it is the air, and here it is the lung condition. So this is the pneumothorax. Okay, so we must see many pneumothorax chest X-ray, and we must learn how to diagnose the pneumothorax in the chest X-ray. Yeah. And then we can see the other injury. Is there injury of the rib, fracture rib or not? But we should not miss these things. Yeah. Main things is the this lung, collapse lung. Yeah. Thank you. Okay, now the clinical presentation of this pneumothorax patient. How a pneumothorax patient present to us, or what are the sign and symptom of a patient of pneumothorax. That is, the clinical presentation is dramatic. Yeah, patient suddenly collapse, patient suddenly become anxiety, restless. So that's why it is telling it is a clinical presentation is dramatic. What are the clinical presentation we will find the tachypnea, or the increase the rate of the heart respiration, then dyspnea, that is the difficulty in respiration, and distended neck vein, and other we may found the clinical condition of the shock, or the pulse is increased, BP is low. Then if we see the clinical examination, we will find the tracheal deviation, what we see in the X-ray. Then in hyperresonance and decrease or absent breath sound. This is very important. Yeah. In the right, that side, this percussion node will be hyperresonant, and that side percussion node may be within the normal or dull. But hyperresonance is important. That indicate that air within the chest cavity, more air, and breath sound. As lung is collapsed, so we will not find any breath sound. Now, most important thing, say, tension pneumothorax is a clinical diagnosis. It is highlighted by the Bayesian laughs. In the Bayesian laughs. So, tension pneumothorax is a clinical diagnosis, and treatment should never delayed by waiting a radiological confirmation. This is tension pneumothorax. If it is pneumothorax, not tension, that time we can send the patient for a chest X-ray. If we do this chest X-ray is done in the bedside. So if emergency room have a facilities to chest X-ray, to manage the other things, we can do a chest X-ray. Otherwise, we should not send the patient to in the radiology department or in a clinic or in another hospital for a chest X-ray. If we have the facilities to do a bedside chest X-ray, we will do the bedside chest X-ray. Otherwise, tension pneumothorax is a clinical diagnosis, and treatment should never be delayed for waiting a radiological confirmation. Now, come to the treatment of a tension pneumothorax. Tension pneumothorax treatment is immediate decompression. We learned these two words. আমরা এই দুটা শব্দ মনে রাখবো এবং এই দুটা শব্দ প্রথমে বলবো। স্যার যদি জিজ্ঞাসা করে যে টেনশন নিউমোথোরাক্স ট্রিটমেন্ট কি, আমরা প্রথমে বলবো ইমিডিয়েট ডিকম্প্রেশন। তারপরে স্যার হয়তোবা জিজ্ঞাসা করবে এটা কিভাবে করা হয়, তখন আমরা পরে জিনিসগুলো বলবো। সো পরীক্ষায় আনসার করার যে স্টাইল বা যেটা সবচেয়ে ভালো তার মধ্যে এটা একটা। এটা শুধু এই চ্যাপ্টারের এই অংশের জন্য না, আমরা অন্য চ্যাপ্টারও ঠিক এভাবেই পরীক্ষা আনসার করবো। আমরা একবারে গড়গড় করে সব বলে যাব না। হ্যাঁ, দিস ইজ দ্য সিক্রেট অফ ডুইং গুড ইন এক্সামিনেশন। সো হোয়াট ইজ দ্য সিক্রেট? ওয়েন স্যার আস্ক আস that what is the treatment of tension pneumothorax, we will tell that, sir, the treatment of tension pneumothorax is immediate decompression. Then sir will ask how you will do the decompression. Then I will tell that there is the insertion of the large bore cannula in the second intercostal space in the mid clavicular line. So we are taking the time, we are giving the answer in a smart way. That is the secret of doing good in the examination. Then holo next what we will do, next we will do a chest tube drain dibo, where it is the in the safe angle, safe triangle in the fifth intercostal space. In different chapter we will discuss how to insert a chest drain, where to insert a chest drain, what are the indication of chest drain. It is not within this chapter, so that's why I am not going the details about the chest drain. So this is the treatment of a tension pneumothorax. What is the treatment of tension pneumothorax? The treatment of tension pneumothorax is immediate decompression. How you will do the immediate decompression? I will insert a large bore cannula into the second intercostal space in the mid-clavicular line. That will be my answer. Sorry. Next, come to the massive hemothorax. Another condition, massive hemothorax. What is this? Most common cause of massive hemothorax is blunt injury. And from where the blood is coming, blood will come from intercostal vessel or occasionally from the internal mammary artery secondary to the fracture of the rib. So how a massive hemothorax will be developed for this condition? These vessels are very close to the heart, so their blood flow in a force is more. That's why they are not, their bleeding is not stopped spontaneously. Vessel is small, but bleeding is continuous. That's why this type of clinical condition, this type of hemorrhage developed in the vessel of the chest. Accumulation of blood in a hemothorax can significantly compress the respiratory effect, compress the lung, and threaten. It is a, that's why it is a immediate life-threatening condition. Okay, so how we will treat a massive hemothorax? Massive hemothorax, here there is a indication of thoracotomy. Where after that is when we will open the chest and identify the vessel, and we will ensure the hemostasis of the blood. There is an indication. This indication we must remember. What are the indication of emergency thoracotomy in massive hemothorax? What are the indication of thoracotomy, or what are the indication of emergency thoracotomy in hemothorax patient or massive hemothorax patient? What are the indication? First, 1500 or the 1500 ml blood if initial drainage, or after the insert of a chest drain, 1500 ml blood come out. This is one indication. Another, what is 200 ml of blood per hour. 200 ml of blood coming per hour for continuous 3 to 4 hours. These are the two indication of emergency thoracotomy in a hemothorax patient. So we should remember it. So আমাদেরকে মনে রাখতে হবে যে ইমার্জেন্সি থোরাকোটমির ইন্ডিকেশন কি। একটা ইন্ডিকেশন হলো যদি আমি চেস্ট ড্রেন দেওয়ার পরে দেখি আমার এট এ টাইম 1500 ml ব্লাড চলে আসে, এটা একটা ইন্ডিকেশন। সেকেন্ড ইন্ডিকেশন হলো আমার প্রতি ঘন্টায় 200 ml করে ব্লাড আসতেছে 3 থেকে 4 ঘন্টা। আমি হয়তোবা পেশেন্টকে ফ্লুইড দিচ্ছি, আমি ব্লাড দিচ্ছি, কিন্তু আমার দেখা যাচ্ছে যে চেস্ট ড্রেনে এরকম 200 ml করে প্রতি ঘন্টায় ব্লাড আসতেছে। তখন আমি বুঝবো যে আমার এই ব্লিডিং কোনোভাবে স্পন্টেনিয়াসলি স্টপ হবে না, আমাকে ইমার্জেন্সি থোরাকোটমি করতে হবে। ওকে, থ্যাংক ইউ। নাও ফ্লায়াল চেস্ট। হ্যাঁ, ফ্লায়াল চেস্ট, another condition, another immediate life-threatening condition, flail chest. So this condition usually result from blunt trauma associated with multiple rib fracture. So we should know it. Flail chest is associated with multiple rib fracture. What is this? Is defined as 3 or more rib fracture in 2 or more places. So we must remember that. The definition of flail chest. How we will confirm that there is a flail chest? We must remember that there is 3 or more rib fracture, or 3টা থেকে বেশি rib fracture হবে in 2 or more places, অর্থাৎ 2 এর অধিক জায়গায় 3টার বেশি rib fracture যখন হবে তখনই ফ্লায়াল চেস্টের মতো একটা ক্লিনিক্যাল কন্ডিশন তৈরি হবে। ইন ইংলিশ 2 or more 3 or more rib fracture in more than 2 places. If this type of fracture is happen, that times flail chest will develop. The blunt force typically produce a underlying pulmonary condition. The diagnosis is made clinically. This flail chest also a clinical diagnosis we must do by clinical examination. So we should learn to how to diagnose a flail chest. So now come the confirmation of diagnosis in the chest wall can be observed paradoxical motion of the chest wall segment. This I will draw attention of all to paradoxical motion. Paradoxical motion. Jokhon amra during the inspiration, our chest wall is going outside, right? During inspiration, our chest wall is going outside. During expiration, our chest wall is coming inside. Paradoxical means opposite direction. Paradoxical means opposite direction. That is, when we are taking the inspiration, our chest wall is supposed to go outside, but some part of the chest wall is coming inwards movement. This is the paradoxical movement. If you see once in a lifetime, you will never forget this. So there are some clinical condition in medical science you must see for a once in your this 5 years medical education time. Okay? Or if I included the fellowship, it will be 10 years medical education time. Yeah? Then you will never forget this. So this is the paradoxical movement. So now come to the what is the definition of flyal chest. If there is a 3 or more rib fracture in 2 or more places and chest wall is moved paradoxically during respiration, this clinical condition is called flyal chest. This definition is not written here. That's why I told it. You can learn it or memorize it from another book, no problem. So what are the clinical condition of flyal chest? On inspiration, loose segment of the chest is displaced inward. What just I'm telling. On expiration, it will go outwards. And then other clinical condition we will found. Then what are the investigation for flyal chest? That is the CT scan with 3D reconstruction is the investigation to confirm the diagnosis, but we must do the diagnosis in clinically. Then come to the treatment of flyal chest. Treatment of flyal chest. See what is written here. Traditionally, mechanical ventilation was used to spleen the chest, or the spleen means to treat the flyal chest. But this mechanical ventilation is costly and is also have morbidity. So there are some shift of in the management of the treatment of the flyal chest. So what is the current treatment of flyal chest? That is the first admission to the patient in a ICU, and then painkiller, then oxygen administration, adequate analgesia, and chest physiotherapy. This is the treatment of flyal chest. When we will read in the examination, or when sir asks how you will treat a patient of flyal chest, we must first consider the admission of the patient. That, sir, we must admit the patient in a hospital and in an ICU setting. In an ICU setting, maybe ventilation is not needed, but it should be in an ICU setting. Then we will administer, we will give the oxygen, we will give adequate analgesia and physiotherapy. And if a chest drain in situ, jodi ekta chest drain thake, amra sei chest drain we can give the analgesia in the chest drain. And in some patient, ventilation is needed, and surgical stabilization of the rib. Eta ekta amader ekta janar byapar. Can we fix the rib? Yes, we can fix, but it has limited. It has limited for only some patients. Suppose we should do a thoracotomy for a flyal chest patient. That time we will fix the rib. Otherwise, we will treat the flyal chest in conservative condition. Conservative condition. What is the conservative condition? We will admit the patient in ICU. We give the painkiller. We will give the oxygen, and we will give the physiotherapy and other associated treatment like fluid, then if needed catheter, if needed omeprazole, and all other things we should write later. Now this may be the last slide for today. Here this is 3 things I will draw your attention. What is immediate thoracotomy, that is emergency sternotomy and planned thoracotomy. Or 3 type of thoracotomy is written here. In emergency condition, we will do 3 type of thoracotomy like laparotomy. What is this? Immediate thoracotomy, emergency sternotomy, and planned thoracotomy. So, sorry, what are the indication of immediate thoracotomy? Sorry, what are the indication of immediate thoracotomy? That is if there is a massive hemorrhage, or to control the bleeding, then if there is a cardiac tamponade, if it is needed that internal cardiac passage, or that CPR is not sufficient, that times we will open the chest, we will put our hand and we can give the cardiac message. This is the internal cardiac message. So in these 3 conditions, we will do the immediate thoracotomy. And then emergency sternotomy, we will only open the sternum, and in anterior chest wall or heart, we will do like that cardiac massage or cardiac tamponade. In that case, we will do the emergency sternotomy. We will not check the lung and other thing. That's why it is telling emergency sternotomy. And the final is the planned thoracotomy. Our patient is stable, like this hemorrhage patient. For last 3 hours, patient is coming 200 ml of blood. In that case, we will arrange the OT, and we will arrange the all other blood. Anesthesia is confirmed. Then we can take the patient to the OT and do the planned thoracotomy. So that's all for today. This is chapter 27, torsotoma, first part, or the disease related to the chest injury. I discuss with that. And in the next class, inshallah, I will discuss in the later part. And there is many important topics like solid organ injury, perforated trauma injury. So in next class, I hope you will join and you will enjoy. Thank you, everybody, and good night.